to join?
I'm trying to.
There we
Can
go.
can you hear me? I can't see anything, but I can hear you.
Okay, I can see you. Um, I know I'm sharing the slides. I think everybody else should just be able to see the slides. Um, Dr. Parton, are you able to see the slides?
Yes, I can see the slides.
Perfect, and we can hear you. All right, so are you okay if we go ahead and get started then?
Yes, please. Let's go
All
ahead.
right. So just so everybody's aware who's speaking, my name is Megan Sawinski and I'm with Altarum. We are working with DMS on this project and getting the Medicaid Advisory Committee and back stood up. So very quickly, I'm going to come to this next slide and just read over some housekeeping before I turn it over to Dr. Parton, who will be leading this meeting. For those who are attending in person, we want to please make sure to keep conversations to a minimum just because that mic will pick everything up. And raise your hand when you wish to speak. There will be chances for discussion. And please speak loudly and clearly so that everybody on Zoom is able to hear you. We also will ask that if you're in person and speaking, to please say your name before you do start speaking so we know who's speaking. And then for those on Zoom, we will ask that you please stay muted unless you want to speak, to use the raise your hand reaction when you do want to speak so that we can call on you. And that can be found under the reactions button at the bottom of your Zoom screen. There's a little raise your hand feature. And then, if possible, especially if you're on the Mac, to have your camera turned on. That way we can see you and everybody can engage. And then, if you have any questions during the meeting, you can always put your question into the chat. We do have somebody from our team that will be monitoring the chat to answer questions or to make sure that your question is addressed during the meeting. So with that, I am going to flip it over to the agenda and I will turn it over to Dr. Purton and she will take it from here.
Okay, good morning, everybody. And Megan, I can't see myself and I can't see anybody and I can't see if anybody's raised a hand. So if you would remind me of that, if somebody does raise their hand, to let me know.
Yep, we will do that.
And
Thank you.
Beth, we can see you.
Okay, thank
Yeah.
you.
Uh-huh.
Okay, so we've called the meeting to order. Let's go ahead and do roll call.
Okay, give me just 1 second to pull up the list here. Okay, Barry Martin. Barry Martin.
I think Barry told Sheila that he was not
Okay.
going to be able to attend.
Yes. Okay, Dr. Beth Parton is here. Brian Proctor. Proctor. Okay. Dr. Catherine Hanna.
Here.
Perfect. Dr. Dwight Burchett. Dr. Dwight Matthew Burchett.
He wrote into the chat that he is here.
Oh, thank you.
Of course.
Eric Wright.
I am here. Good morning.
Good morning. Heather Smith.
Here.
Perfect. Let's see. Dr. Justin, I'm sorry, Kawasa.
This is Garth Bobrowski. I'm taking his place representing dental today.
Okay. I'm sorry, can you say your last name for me one more time?
Bobrowski.
Okay. Kent Gilbert.
I'm present and accounted for.
Perfect. Dr. Kelly Evans. Dr. Kelly Evans. Let's see. Kendra Marsh.
I'm here. Good morning.
Good morning. Linda Ross.
I'm here.
Mackenzie Wallace.
Hi, I'm here.
Hi. Nina Eisner,
I'm here.
Becky Rourke. Becky Rourke. I can never say this name. Rourke. Philip Travis. Let's see, do we have Philip Travis? Um, Ronald Butler. Ronald Butler. Dr. Sarah Moyer.
Good morning.
Good morning. Let's see. Susan Stewart.
I'm here. Good morning.
Good morning. Tanya Whitfield.
This is Carrie on behalf of Alternative. She texted us, she will be here, just be a little late today.
Okay, thank you.
Uh-huh.
Theta Simpson Mosby. Is it Theta or Theta Simpson Mosby? Okay, Zachary Hart.
I'm here.
Hello. Okay, so that is the MAC members. I was trying to see if we make sure we have a quorum. 1, 2.
Aisha, this is Emily Beauregard. I didn't hear you call my name, but I'm here.
Okay, thank you. I don't see you on here. I'll just write you in real quick. Do we have Dr. John Langfield here? Dr. John Langfield. Dr. Katie Marks. Lisa Dennis.
Danielle Corey here for Lisa Dennis.
Okay, thank you. Lisa Lee.
Yes, I'm here.
And Tavon Harrington. Okay, it looks like we do have a quorum. 1, 2. Yes, we do.
Okay, thank you, Aisha. Next slide is disclosure of conflicts of interest. If anybody should have any disclosure to make, please do so. And as we move along, if there's any issues that you have a conflict with, please let us know. Okay, approval of minutes. Can we have a motion to approve the minutes from the last meeting, please?
Susan Stewart, I'll make that motion.
This is Emily Beauregard. I'll second.
Any discussion?
Love the new format. So much easier.
Thanks, Nina. Any discussion? Okay, all in favor say aye.
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 Any opposed? All right, so moved. Next up on the agenda is the back meeting report, and that will be Emily.
Thank you, Dr. Parton, and good morning, everyone. I'm Emily Beauregard. I'm the chair of the Beneficiary Advisory Council, and happy to be here with you all today. Happy veto period for all of you who have been working during the legislative session. The BAC had a hybrid meeting on March 9th. We had a quorum present, and based on feedback that we had received from previous meetings, we had agreed to focus our agenda on HR 1 planning, so the changes made by the Big Beautiful Bill and common issues that families were having with home and community-based waiver services, including electronic visit verification or EVV, participant-directed services. We use the term PDS, and workforce shortages. So in preparation for the meeting, we had requested additional guidance from DMS about the electronic verification or EVV process. and what waiver participants and families can do when they're traveling or if they have no power or internet service. These situations are pretty common, as you can imagine, and can create logistical problems for participants and caregivers who need flexibility. BAC members raised concerns that agencies may be interpreting the EVV requirements differently or inconsistently. And following that discussion, BAC members voted to recommend that DMS provide additional clarification to all HCBS agencies regarding EVV policies, particularly related to checking in and out or clocking in and out while providing services in community settings. So really wanting to make sure that families didn't need to stay home, that waiver participants didn't need to stay at home in order to get services, but they could actually get services while they're out in the community. BAC members also shared the challenges that they often face when trying to access waiver services, particularly in rural communities where provider availability is limited. Members noted that families sometimes struggle to find agencies willing to provide services under certain waivers. Some members reported that there are only a small number of available providers in their region, and at times there aren't any. Workforce shortages were discussed as being a really significant barrier to service access, with members talking about concerns with wages, training, workforce support, and staff turnover among service providers. Members also raised concerns that limited staffing prevents families from receiving the full number of waiver service hours that they've been approved for. So this makes the option for participant-directed services incredibly important for some families, and then that comes with its own challenges. So it felt like during this meeting, we were really just starting to scratch the surface on some of these workforce issues, and we agreed to keep this topic on the agenda for our upcoming meetings. Finally, we spent a good amount of time discussing the impact of the Big Beautiful Bill, or H.R. 1, the new federal requirements that states must implement over the next couple of years, and how BAC members can be involved in the planning process. Senior Deputy Director or Deputy Commissioner Veronica Judy Cecil provided an overview of these new policy requirements and Kentucky's planning activities related to implementation. We also touched on potential impacts of state legislation, including House Bill 2, if you've been following that bill, also called the Kentucky Medicaid Reform Act, which actually just passed the legislature yesterday evening. At the time we met in March, House Bill 2 had different requirements than the federal law: earlier implementation timelines, stricter eligibility requirements, higher copays, and that caused a lot of concern about how the state was able to, plan for implementation of the Big Beautiful Bill while these other changes were sort of pending and could actually move up those timelines and make some of these things more restrictive. But I'm happy to report that the final version of House Bill 2 that passed both chambers last night brought most of those changes close to the federal minimums, aligned timelines with federal requirements, and I think that's going to make planning for H.R. 1 implementation much, much less difficult. It's already going to be difficult, but it at least won't be exacerbated by these faster timelines or stricter requirements. DMS also shared a summary of their implementation planning timeline and activities, including communication materials, website updates, email and text notifications, verification forms, and frequently asked questions to support beneficiary awareness. These aren't things that are developed yet, but they are in the planning process. And DMS walked through Kentucky's current eligibility renewal process and potential staffing and workload impacts related to those federal policy changes. BAC members discussed their concerns, our concerns about new eligibility requirements and policy changes that could create additional challenges for vulnerable populations, particularly individuals experiencing homelessness and those without stable income documentation. Members also emphasized the importance of ensuring communication materials are clear, accessible, and easy for beneficiaries to understand. I think that's been an sort of perpetual problem, something that we've worked on for many years and still need to really focus on moving forward. Along those lines, DMS shared that BAC members would be invited to participate in focus groups and a notice improvement work group to ensure materials are understandable and accessible for beneficiaries. Since that March meeting, DMS has held 2 focus groups, which many of our BAC members were able to attend. These were good opportunities for beneficiaries, for caregivers, as well as connectors, community health workers, and advocates to ask questions, to voice concerns, and most importantly, to share their experience with current application and renewal processes, the eligibility verification process, and communication issues. Some specific issues that were raised were related to confusing or delayed notices that require action in a short time frame, having trouble creating a Connect account or getting locked out and not being able to access your account, document upload issues that frequently result in documents disappearing from the Connect system, and confusion about what documents are needed to satisfy a requirement. Getting help from someone at a DCBS office or over the phone when there's a problem, and inconsistencies between policy and practice when someone receives the wrong notice, for instance, or is denied when they're technically eligible, those sorts of things. The bigger takeaway for me, though, is that most Medicaid beneficiaries have no idea whether they are eligible under traditional or expanded Medicaid, and that is already causing confusion and anxiety related to these new requirements for community engagement, the 6-month renewals, and copays. Many waiver families and parents of children assume these changes will apply to them. And while many of us on this call today probably know that that isn't the case, that really doesn't change the fact that people are confused and are making assumptions that their family members or loved ones could lose their coverage. So one way to address this would be to make sure that every notice that is getting sent to households clearly identifies each member of the household's eligibility, either as expansion or traditional. And along those lines, how we're categorizing people who will actually be subject to these new requirements. The exemptions are also really confusing for folks. So we have to figure out a way to make that process as clear and as straightforward as possible. The BAC did make one recommendation at our March meeting, which I mentioned earlier, that DMS provide additional clarification to all HCBS agencies regarding EVV policies, particularly related to clocking in and out while providing services in community settings. And then based on member feedback, we plan to continue monitoring EVV challenges, actively working with DMS on HR1 planning, and discussing waiver waiting list and workforce issues. And our next meeting will be on May 11th. With that, I'm happy to answer any questions people may have. And I know I have some fellow BAC members on this call if you want to bring up anything else.
Thank you, Emily. I have to say that you're right on point with all of your points. Coming from a rural area, those things that you've addressed are very much a concern for providers here, and getting the services for people, and also people understanding what they're eligible for, if they're eligible. I can't tell you how many times patients have brought letters to me and they have no idea what the letters say, or they can't even read them. Thank you for all of your advocacy. Anybody else have any comments or questions for Emily? Okay, well, thank you. We'll move on then. Commissioner, you are up next.
Good morning, everyone. Happy to be here today. I think we do have some updates. We are going to go into HR1. We are also going to, I'm mainly going to talk about HR1, and then we're going to have Leslie and Carmen talk about the things that are going on in our behavioral health department. So, as you all know, we are coming to the end of a legislative session, so we are keeping an eye on all things legislation that impact Medicaid, and particularly, as Emily had mentioned, House Bill 2 and some of the budget bill. We're still digesting that. Not sure we'll have a lot of information, but we'll go through and talk about, I think, House Bill 1. Can we go to the next slide, please? Yeah, let's go get right into to House Resolution 1 and some of the things that we're doing to come into compliance with those provisions. Next slide.
Commissioner Lee, was this
Yes.
where you wanted to share your own slides?
No, I don't. I do not have those up. So thank you for asking, but we'll just go ahead. Can I control from here? I don't think I can. So I don't have mine, so we'll stick with these.
Okay, give me 1 second. Let me get this pulled back up. Hold on.
Okay. Sorry
y'all.
about that.
Give me
Yeah.
1 second.
I typically I had said yesterday that I wanted to do my own slides because I always feel like that next slide, please. It has adds a little bit of a delay in there, but we'll get those up here in just a second. Yeah, just as a note, my grandson is actually a page at the legislative down at the house, and he did not get home until 1:30 this morning. So I know that they were very busy working up into the night to finalize a lot of the bills that they have been working on, and he was absolutely worn out. I guess the good thing is they those that work in the session like that didn't have to go to school today, so that was a good thing. All right now. Okay, good. Here we go.
Sorry about that.
My apologies. I was a little bit late getting to the start this morning. So we're going to
all
talk.
good.
Okay, House Resolution 1. And our goal today is just to provide a clear overview of the changes and some of the things that we're doing. And again, this is informational only. This is not our final briefing. So some of the details are still being developed as we go along. So everybody knows what HR 1 is. It's House Resolution 1 that has some significant changes to Medicaid, in particular, how we do state directed payments. It has work requirements and community engagement for Medicaid expansion members. And it also has some provisions related to cost sharing and just a lot of different things that are going to make us change the way that we operate our program going forward. It's some of the other things that are going to impact the program are the eligibility redeterminations for individuals. And almost all of this is directly designed to make changes to how we administer the program as it relates to Medicaid expansion members. Next slide, please. So the main thing that we're working on right now, of course, are community engagement or work requirement activities. Individuals who are in the Medicaid expansion program will have to meet community engagement or work requirements beginning January 1st of 2027 in order to maintain their benefits. That means that they are going to either have to work at a job for 80 hours a month, do job training, go to school, or do some volunteering in the community. And again, this is required by federal law. We cannot choose to skip this and not implement. There are some provisions that will exempt some individuals, and we'll go through that in a minute. But again, it starts January 1st of 2027, but we have to have our system ready by September the 1st of 2026. So that's coming up in 5 months. And so we have a very compressed time frame that we are going to have to implement. And the big heavy lift on that is their information technology systems or IT systems, because this is going to impact our eligibility system. We will have to have indicators to identify those individuals who are going to be subject to work requirements as we go forward. So that's one of the main focuses that we're looking at right now. Next slide, please. So the community engagement requirements, who has to meet them? Again, adults age 19 to 64 that are in the program based on the Medicaid expansion population. So it's also, you know, those are the individuals who are between 100 and 138% of the federal poverty level. As we said, there are some exclusions to individuals who don't have to meet those community and work engagement requirements. And just a little bit of background, you all know we have about 440,000 Medicaid expansion members in the Medicaid program. So that's the population that we're talking about. And in July of last year, we had to submit a waiver to the Centers for Medicare and Medicaid Services that was based on legislation. And when we did that exercise, and out of those 440,000 Medicaid expansion, we identified about 70,000 that we thought would be subject to the work requirements. So that's the population that we're talking about. And the reason that it went from the 440 to the 70,000 is because some of those individuals are already working. It also, we will exclude individuals with a disability, pregnant women and individuals in the postpartum period, medically frail individuals, which we are still waiting on CMS to help us with a definition on what actually constitutes medically frail. CMS is supposed to come out with more information and guidance, and actually, I think a final rule in June of this year. But again, we have to have our system ready by September. So the longer that takes, it kind of puts us in a little bit of a bind as we design the system. Also, it excludes people who are caring for dependent children under the age of 13 or a disabled adult. And some individuals already receiving certain benefits, and then some other individuals as designed. So our goal definitely is to make sure all of those exempt individuals are clearly identified, so they're not asked to meet those community engagement or work requirements. Next slide, please.
Commissioner, can I ask a quick question?
Sure.
Is the postpartum period still 1 year?
Yes, it is.
Thank you.
So yeah, pregnant women who deliver their babies have eligibility for 1 full year after their delivery. So another impact that's going to, for Medicaid expansion members is eligibility renewals. So currently we do a recertification every year. We have to do that by federal law. But starting in January, we have to do that every 6 months for individuals who are in the Medicaid expansion. Again, that's those 19 to 64 who are between 100 and 138% of the federal poverty level. This may, result in some individuals losing coverage if they don't return information. Now, the good news is our eligibility and enrollment system is one of the better ones in the nation, and we have access to a wide variety of data sources that helps us document and prove that those individuals meet those eligibility requirements without individuals having to take action on their part. That's what we call the ex parte renewal. So our goal is to use every resource that we can to make sure that everyone who is eligible remains enrolled in the program. And we're going to do that by taking on as much of that responsibility as we can for that documentation and making it easier for individuals who have to supply documentation to come into the program. The coverage start date is currently Medicaid can go back for 3 months. When someone completes an application, there's usually a question that states, do you have medical bills or previous medical bills? And if so, we can make that eligibility start date retroactive to 3 months. That's going to change going forward for individuals who are in Medicaid expansion. We can only go back 1 month retroactive. Other individuals, we will be able to go back 2 months for that information or for that eligibility to begin. non-citizen eligibility. There are some individuals that are currently covered that we will no longer be covering beginning October 1st of 2027. Some examples of those include refugees, some asylees, humanitarian parolees, and some individuals with a special immigrant visa. This will not impact emergency time limited Medicaid. Currently, we have emergency time limited Medicaid that covers things such as births, for example. Emergency time limited Medicaid will still be in play. However, there are certain non-citizen eligibility groups that will not be covered under the Medicaid program beginning October 1st of 2027. Next slide, please. And cost sharing. Cost sharing is going to be effective on October 1st of 2028. Again, this is for those individuals who are in the Medicaid expansion population. The House Resolution 1 does lay out that individuals with 100 to 138% of the federal poverty level will be subject to cost sharing. So we interpret that as individuals who make less than 100% of the FPL will not have to meet those cost sharing requirements. But again, this begins on October 2028. That's a little bit later than the implementation of the community engagement, which gives us a little bit more time to design and fix our system for the cost sharing requirements. And in some cases, members may pay part of the cost for certain healthcare services. And this usually comes in the form of copays, like so cost sharing will be implemented again. Members will have a certain out-of-pocket amount. Again, we're keeping an eye on House Bill 2 and the budget bill because it does lay out some specific provisions and cost sharing amounts. Still analyzing all of that, trying to design our system. And as previously, we did have cost sharing in the Medicaid program at one time. And the House Resolution 1 contains that same provision that out-of-pocket cost sharing in the form of copays cannot exceed the family's 5% of the family's income. So that's something to keep in mind too.
No.
Sorry, can you?
Yeah, I think it's Brian needs to mute his phone. Thank you.
Okay, thank you.
And Commissioner Lee, when you're done, we do have a question in the chat that I will call on.
Okay, I've got just a couple more slides, and if we want to get through those, and then we'll get to those questions. So again, keeping an eye on that legislation specific to Kentucky as it lays out those amounts. And here are our House Resolution 1 priorities with a little bit of a timeline in there. Our implementation work spans all of 2026. So we have definitely been having lots of planning sessions, lots of conversations. As you all notice that Deputy Commissioner Veronica Judy Cecil is not in this meeting because we had conflicts, and she is in a application development session right now as we are going through all of this, actually planning for House Resolution 1 priorities. So in early 2026, we created work groups and began reviewing policy impacts. In the spring of 2026, we're going to focus on prioritizing changes to the IT system and begin stakeholder engagement. So that's very, very soon coming up here. And then in the summer, we are going to share public-facing materials and conduct early outreach related to community engagement. And I said that we have to have our system ready by September the 1st. That is because that's when we have to start notifying individuals that they will have to meet work requirements and community engagement activities in order to maintain their eligibility. So in January 2027, it's the required start date for community engagement. And Medicaid eligibility changes. And so the timeline is really short, but we're going to try to get as much feedback as we can as we move forward. We know this is a real heavy lift. Our IT system, again, major changes. We definitely have to develop some notifications for our members. We are, in the early stages of drafting those. And then again, really compressed timeline, but we are definitely wanting to get all that stakeholder input as we can as we move forward. Next slide. So we're implementing through HR1 through several connected work streams. Of course, policy work focuses on updating rules and guidance to meet federal requirements. We'll have to modify our regulations in order to comply with the provisions in HR1. Our IT system also ensures eligibility and other Medicaid systems can support the new rules and reporting needs. And our communications work focuses on helping members and partners understand what is changing. Stakeholder engagement supports all three of these areas. And these efforts must stay aligned so that rule systems and messages all match, because we want everything to be as clear and kind as possible as we move forward so that individuals understand what their level of effort is and in maintaining their eligibility and keeping us informed of any changes. Next slide, please. This is our process for implementing policy changes. As I stated, we began our work from a policy perspective. We've also already completed lots of detailed reviews of HR1 with state laws, regulations, waivers, and the Medicaid state plan have been reviewed. So we know where we have to make changes, where there's conflicts. We have also created a timeline that we just went through, plan for writing and updating policy changes, all of those changes that we have to make. And we're now identifying areas where the federal law allows some choices and maybe a little bit flexibility, because we want to incorporate as much flexibility as we can to make sure that, again, that everyone who is eligible for the Medicaid program remains in the program. Our next steps include required approval processes for state law changes. And that may involve public hearings and CMS review. Every bit of the work that we do will be subject to CMS review and approval. And we're also monitoring the new legislation to ensure alignment with HR1. Next slide, please. So our process for implementing our system changes, this is a heavy lift. Our IT systems, we have an eligibility system that also feeds into another system called our Medicaid Management Information System that houses all of our claims, that houses some eligibility information too. So we have to make sure all of these systems talk to each other and pass information along that allows our individuals to remain enrolled. So we have created an IT work group to manage all of those system updates. We're making sure that our policy decisions are translated into those technical requirements. And we do anticipate gathering stakeholder feedback before those system changes are finalized. Again, testing is very important to confirm that all those systems are working correctly and that we are gathering information that CMS can audit to make sure that we are in full compliance with House Resolution 1. Next slide, please. So communication is definitely a major part of a successful implementation. We're identifying materials, which materials are needed and which audiences they may serve. We're drafting those materials and right now, and a communication plan will guide timing, format, and delivery of all of our materials. We intend to have stakeholders review materials and provide feedback before they're finalized and approved. And materials include frequently asked questions, fact sheets, one-pagers, toolkits, and member notices. And the goal is to provide clear, simple, and consistent information across all channels. Next slide, please. So our stakeholder engagement plan, we know that stakeholder engagement input is very critical to this process and will lead to the success. Draft communication materials will be shared with the Beneficiary Advisory Council and the Medicaid Advisory Council for early feedback. We also plan to create a notice improvement work group, very similar to the one that we had during the public health unwinding. This group was going to help us focus on that clarity in the language and make sure it's easy to read and understand for our members who are going to be subject to those community work engagements. Again, as I said, we've also created a separate IT system focus group. That group's going to provide feedback on system changes from a user perspective, because we know that early feedback is very helpful as we roll out this design and make sure that we don't miss anything. That's going to be very vital to the success of this implementation. Next slide. Thank you. So we're very much underway with ensuring that we can meet the House Resolution 1 deadlines and requirements to ensure that we're successful in a smooth rollout for all of our members. Our immediate steps include continuing to draft policies and regulations. IT system design and development is going to move forward alongside with our policy work. Public-facing materials will continue to be developed and refined. And all CHFS contact the Cabinet for Health and Family Services. We're all intent on ensuring stakeholders remain engaged throughout the implementation with the overall goal of meeting federal requirements while minimizing disruption to our Medicaid members. So some of this stuff like community engagement is going to be very new to our members. And while cost sharing is later on, it's not really new, but I think that we probably have a lot of members who were not subject to work or to cost sharing when they were enrolled in the program because they're very new. So all of the communication that we do is going to have to be very clear, and we're going to have to help those individuals who may need a little bit more assistance with meeting those working community engagement requirements, such as those that are self-employed, where we may not have access to some of the information that we will need to document their compliance with those provisions. And I think next slide, I think we are in the question and answer session now. I think we did see some questions in the chat. So
we did. Commissioner
Okay.
Lee. I'm going to go ahead and Kent, you can go ahead and ask your question. He raised his hand during here.
Okay.
Yeah. Thank you so much for that comprehensive overview, and thanks for that. I know this is a lot of it's drinking from a fire hose for you all as
Yes.
well. I appreciate the attention to the detail. I have a couple questions. One, the first came up when we were talking about withdrawal of emergency Medicaid payments for undocumented persons. Who covers those costs? Somebody shows up at an ER with an emergency birth or an emergency in a car wreck. Who will then eat that cost?
Well, the emergency time limited Medicaid is still in place. So let's say an individual goes to the hospital and delivers. Those costs will still be paid by Medicaid and the federal government, the emergency time limited only. But for individuals who were previously or eligible for the Medicaid program, such as those individuals who the parolees and the asylees that we discussed that can no longer be covered by Medicaid, those costs will, if they do not and cannot purchase private insurance somewhere, then those costs will be uncompensated care for the hospitals, for example, if they go and it's just an emergency room visit. It's not something that's considered time limited because not every emergency room visit is considered emergency time limited Medicaid. So if it's just or a doctor's visit, those may be uncompensated care.
Yeah. Okay. Good. Thank you for clarifying. The second was more of a comment about as you're testing the IT. I think we can all agree that the user experience has been of a challenge in terms of and frankly a huge barrier to folks applying for benefits. So I'm really hoping that part of the planning process would include the BAC. In other words, members of the BAC should be testing your user experience.
Yes.
And possibly even some of the members here who are also providers, so that both providers and actual folks engaging. This is not on you. I think it has to do with the nature of software development of this complexity. But frankly, what you see depends on where you sit, and most programmers do not sit in the seats of those who actually use the system. So I really think it will take pressure to get, I don't know if it's Deloitte doing it for us, but whoever is developing that, they must, absolutely must be held to account to make a user experience that is actually functionable.
Thank you. Thank you for that. We agree. We definitely need our members, individuals who are going to be using this system to test it. And as I said, we have to have this ready by September 1st. So we're going to try to get as much feedback as we can. But I want you all to know that as we roll this out, your feedback is going to be really critical, not only in that planning phase, but after it's rolled out. If there's something that we need to tweak, to change, that we really need to look at that, because we want this to be a really good experience for our members. We definitely know that sometimes technology, even when it's working as it should, is sometimes quite complex. So I appreciate that. We definitely look forward to having you all get as involved as you can in this short time frame.
Thank you.
Okay, I have a hand raised from a Brian's G. I'm not sure who that is. Brian, you can unmute yourself and ask your question.
I just had a quick question based on the lower average of non-reimbursed ER visits and things like that. And I guess this is a question, I believe.
I'm sorry, Brian, you've cut out.
Place, so when we this still.
I'm sorry, Brian, you're cutting out.
Share and receive, correct?
I'm sorry, Brian, I couldn't understand the question. You cut out a little bit. And now you're on mute, Brian. I can't hear. Is it possible that you can type that into the chat, that question into the chat, or can you try again to see if you're not cutting out?
Yeah, can you hear me now?
I can hear you.
You can? Okay, this is Brian Levanian.
Okay.
I was just responding to the question before about the ER scenario where hospitals might not get paid for services. In that situation, typically hospitals can apply for disproportionate share and still receive reimbursement for the number of services that are going unreimbursed. I believe that is still in place. So there is some form of reimbursement for that really kind of needs to be looked at to make sure that that's not occurring.
Yeah, that's a really good point, Brian. Thank you. We'll have to look at, the DISH payments. I know in Kentucky, when we had the state directed payments for the hospitals there, that was they received the average commercial rate, and I think that reduced their DISH payments. So we'll have to get some more information on how DISH may be impacted as we go forward. So thank you for that. That's a very good comment.
And Commissioner, this is Steve
Yes,
Bechtel. And I'll just add to that is from a federal perspective, there has been a reduction of DISH allotments. So from a federal level, they're reducing our DISH. So that it's a double-edged sword there, Brian, because we're getting reduced on the federal side of that program.
Right, I understand. I understand, but I just wanted to make it clear that there's some level of reimbursement for those individuals that kind of fall through that crack of no Medicaid coverage, no, they're not paying it for themselves. Somebody is paying for it, so we have to understand that is in place.
Right,
but I agree,
and
it's a double-edged sword.
There's also the other issue of charitable care, but that some hospitals use, but I think what the commissioner was just trying to relay is that any kind of cost sharing, we're paying less, and it's up to the provider to collect that cost sharing from the member, and if the member does not pay it, then the provider's on the hook pretty much, and that's what I think she's just trying to say there.
Gotcha.
And so Yeah, and so Brian, thanks for that. The dish, that's definitely something that we can continue to monitor as we go forward. But some of the provisions in House Resolution 1 and the things that we're keeping an eye on, and some of the bills that are being passed during this legislative session, definitely take money out of the healthcare landscape in Kentucky. The state directed payments, for example. The hospitals and the universities receive about $5 billion per year. Again, that's because we are allowed to pay them through that process through the average commercial rate. Going forward, we have to reduce those payments to the hospitals and until we get to 100% of the Medicare rate. So that's going to be a reduction. In addition, any cost sharing that we implement, again, that is in play in 2028. But the way cost sharing works, if we have a $5 copay, for example, for pharmacy or for hospital, whatever, we will have to reduce the provider payment by the cost sharing amount. So in addition to hospitals losing that money from the state directed payment, there could be some cost sharing specific to non-emergency use of the ER and inpatient. Again, keeping an eye on bills that are coming out of this legislative session to see what the cost sharing may look like, what they're proposing in their legislation, and what actually gets implemented as we move forward. Thank you. Thank you.
Thank you. Zachary Hart has his hand up.
Yeah, so I had a question on the communication side with the participants. Do you have any sense of current Medicaid participants in Kentucky, how aware they are now of all of these things coming? I know it's in the news and there's little bits of things. And, again, I don't know how much people are paying attention, and because they're just got their lives that they're managing. I'm really concerned about that because these are massive changes that are coming and how things are done. And I know we've got a plan about like how to kind of, communicate, but I'm just wondering whether you're already hearing anything from participants to any sort of extent and what kinds of things you're hearing about that.
Yeah, Zachary, I thank you for raising that. Now, we have the same concern because what we've been talking about and what House Resolution 1 says, and everybody says community engagement. What does that mean? So we really have to get back to that work requirement language. And I think the communications that we have are going to have to be very clear. We're going to have some really good instructions for individuals to support to supply any supporting documentation that's required. And I think on top of the work requirements that mandate that individuals have to renew their eligibility every 6 months, or we have to redetermine them eligible every 6 months, is just another added layer of documentation on top of that. So we're trying to make this as streamlined and as easy as possible for our members, because our goal is to keep everybody enrolled in the program that remains eligible. And the good news is I just looked at a national report related to eligibility, redeterminations, and processing, and Kentucky was in the top related to ex parte renewals. That means we can renew. I'd have to get back and look at the number, but it was a very high percentage, well over 70%, that we can renew without the individuals having to take action. Now, that's good on the eligibility side, but when we then have to, on top of that, confirm work requirements, that's where we have a little bit more of a concern. We feel like the redeterminations are going to be administratively, they're going to add a lot of administration onto our workload, and the work requirements will add another layer. So we have your same concerns about individuals not really understanding what's coming down the road, and how we have to educate them, not only in September, but it's going to have to be ongoing education for individuals who cycle in and out of the program, or in new individuals that come in. So the communication is definitely going to be ongoing. Okay. Do we have any other hands up or questions in the chat? So,
I'm
and
gonna,
I
sorry,
was just
I'm
going
gonna,
to
go ahead, Commissioner Lee.
I was just going to say, Emily put a really, really good point in the chat about the budget that was passed yesterday. It does include funding shortfalls for Medicaid. So, if you all have ever heard our Chief Financial Officer, Steve Bechtel, talk at some of the legislative sessions, you hear him say that, there's the triangle, there's the eligibility, there's the benefits, and there's the reimbursement to providers. And those are the levers that we have in order to save money. And none of them are actually good, because if you cut eligibility, that's definitely a payment reduction to providers, benefits reduction to providers. And individuals not receiving services, and overall it could increase the cost, because individuals will forego care until it's till the very last minute. So Emily, thank you for that note in there about the budget. Okay. All right.
Do we currently know as the bill stands now, do we know what the extent of the shortfall is?
And we're still analyzing that right now, and I don't know if Steve has anything to add to that, but I think it's still under analysis because it was passed last night.
Right at 1 a.m.
Yeah, I will say it looks like we're short about 270 million the first year for 27, and that's just state dollars, Kent. That's not, that's in order to draw the federal dollars down, I have to have the state dollars.
Right.
So that's even more than the 270, but the 270 is the state funds. And fiscal year 28, we're about 420 short.
And what do we anticipate the cost of IT development for complying with HR 1 will be?
Right now, we've only been funded. Now, we have two appropriation units. We have an administrative appropriation and a benefits. So what I just gave to you was the benefits side. Mm-hmm. But on the admin side, which is where all the HR 1 activities and the community engagement will be following, we did receive some additional funding for HR 1 immediate needs. I think it was like 35 million. But there's going to be ongoing expenses that doesn't cover. So there's some other things we've got to figure out on that end. And then I'll also say in House Bill 2 last night, on the free conference committee version added another lever of community engagement that we have to do now through the Volunteers of America. And it said that we were given $5 million, which it's not in my budget for $5 million, but I guess they're saying that I have to spend $5 million. So that creates another $5 million shortfall on the admin side. So.
Thank you. I appreciate that. You may not be the right person to ask. I had an earlier question I forgot to ask Commissioner Lee. For volunteer requirement engagement, obviously nonprofits, faith communities, of which I represent some portion, would be obvious places that could use volunteer help. How is it what will we need to do as faith-based organizations, as nonprofit agencies, when someone comes and say, I need volunteer hours? Is there going to be a way that we certify that, or do we have to be pre-qualified to offer it? How's that going to flow?
We're still working all of that through. Those are really good questions, Kent. Some of that we're waiting for some guidance from CMS, but we are in the process of developing a very simple form that someone can fill out and maybe have someone certify that they were actually volunteering, so that we can upload that in the system. And for the first year, the federal guideline, or CMS, has stated for the first year we can take self-attestation on some of these items, but after that we will have to have some sort of auditable and verified format in which they can say, oh yes, here's a document and you did complete this information. But we're trying to pull something together that's very simple, that they can, if they volunteer, they can just log their hours, and if they're, for example, you oversaw them or you knew, then you could just sign and they could upload that to the system.
Got it. Thank you.
If I may, Kent, if I may just be able to expand a little bit more on what I said, the 290 or 269 that I'm projecting to be short in 27, they did put a mechanism in the budget bill for budget reserve trust funds for 200 funds being transferred from Department of Insurance to us to cover any shortfalls, but we have to ask for permission to use those. So that's a first time and that's ever happened. So I'm not sure what kind of hoops and requirements we're going to have to follow through to access those dollars. So as of right now, I'm still showing 290 short, but I mean 269 short, but that's they did have that mechanism in the budget. Out of transparency, I just wanted to point that out.
Thank you for that, Steve. I'm going to take one last question from Chris Lindy. His hands up, and then we're going to just continue to monitor the chat to get us back on track for time's sake.
Yeah, hey, good morning, everyone. So, Steve, I just wanted to follow up on your comments about the budget shortfall. This may be getting ahead of ourselves, but will that be part of the conversation as we go into mid-year and especially 2027 rate setting, benefits, eligibility? I mean, I know we've got eligibility already because of House Bill 2, but just wondering if you guys have had any initial conversations about how we will navigate funding shortfalls if we can't close that gap.
We are still at the drawing board on that. It's still at the 11th hour, last night, but Commissioner touched on it. There's only a few things that we can do to offset this, but at the same time, there's language in the budget bill as well as 695 that does not allow us to make those changes without getting approval through the General Assembly. So it's kind of like underfund, but we need you to make this budget, but you can't pull any of the levers that you have available to offset that budget. So we found ourselves in a little conundrum here of trying to figure out and walk through that. So Chris, I appreciate the question. It's still too early to say at this point, but we are looking at every little thing that we can figure out because it's not something that you can just flip on the switch, right? There's other rules, federal rules, Kentucky, the access rule that doesn't allow us, like if we do a rate reduction, I can't just do an arbitrary rate reduction. And there's certain things I can't reduce because they receive mandated PPS rates or they get cost settled on the end. And so there's items that we're going to have to kind of tread through lightly and try to make the best decisions, but we have not had those
Sure.
discussions just yet.
Yeah, no, that makes sense. And this is probably stating the obvious, but if, the MCOs, if the association, hopefully I can speak on behalf of Tom here, if there's anything we can do in terms of continued advocacy, education of those types of rock on a hard place situations, I think just the better verse that you all can make us, I think collectively we can all rally to try to work through that.
Thank you, Chris. We really appreciate that.
Yeah.
Okay, I think Dr. Parton asked if we anticipate providers withdrawing from Medicaid. At this point, we don't know. So I think we'll just have to continue to monitor, and we'll definitely keep the MAC updated on anything that we see going on in our provider community as far as changes in the number of providers we have delivering services to our members. I think now we can move on to the next segment of the meeting.
Good morning. This is Leslie Hoffman, and I wanted to bring some good news this morning. So I'm glad I can bring that good news before I turn the PowerPoint over to our director, Carmen Hancock. So our 1115 for reentry, which is a flexibility authority for flexibility that CMS allows the state of Kentucky to participate in, allows us to provide services to reentry members prior to leaving incarceration and help them to be prepared to go into the community. It provides for a small packages of services, for example, screening, health-related social needs screenings. We also can connect them to the MCO of their choice. We can also get started with intensive care case management that will follow them for a year after they leave the incarceration setting. And so we're very pleased to announce that as of yesterday, we were approved and went live at 10 a.m. So reentry is live. You will probably start hearing some additional information coming out, social media and things like that. So this does include our 14 prisons here in Kentucky, as well as 6 youth development centers. Of course, in the future, we will be increasing our work with the jails. We have started working with them, but we will start looking at the jails going forward. We also did receive the ability to start drawing down dollars from the grant that we applied for, which we call the CAA grant, but it's really about reentry in general. So I just wanted to let you know that we are up and running as of yesterday at 10. In all true transparency, in order to meet that deadline, we do have some manual workarounds that we're working out this week. It will not be perfect, as you all can imagine. I have been referring to this project as not a 1115 for DMS. This is a Kentucky 1115 as our partners with DOC and DJJ. Just can't thank everybody enough, and the MCOs, and it has just been amazing. And I'm just so proud of our team for pulling this off, and only good things to come. So just wanted to share that information with you. And I'm sure that as I've been asked a couple times since last night, where we are in the process, we'll come back and give you updates as needed. We do have a dedicated TAC for that, returning to society. I'm sure this will also come up in the behavioral health TAC, as well as maybe some work that Thrive does as well. So just wanted to mention that to you today so you didn't feel like you were not in the know. They are preparing social media to go out now. And I will now turn it over to our director, Carmen Hancock, to go over our 1915C HCB, Home and Community-Based Services PowerPoint. Carmen?
Thank you, Dr. Hoffman. Good morning, everyone. Carmen Hancock with the Department for Medicaid Services. I'm the Division Director for Long-Term Services and Supports. And I'm here this morning because the MAC asked for a presentation on some general information on traditional Medicaid services versus waiver services, how eligibility works, what services the different waivers cover, and then just some general history on the Medicaid program. So that's what we're here for today with this presentation. We can go on to the next slide. So this first slide is sort of Kentucky Medicaid at a glance. Commissioner Lee did go through many of these items, but as a reminder, we have 1.4 million Kentuckians enrolled in Medicaid. Of those, 660,000 are children. About 440,000 expansion members, over 65,000 providers serving Medicaid members, and for state fiscal year 2025, we had $20.3 billion in total expenditures for Medicaid. Next slide. So history on Medicaid. So Medicaid was actually signed into law July 30th, 1965 by President Johnson. Kentucky adopted the Medicaid program in 1966. So Medicaid was created to provide medical benefits to low-income people that didn't have adequate health coverage. That included children without parental support, caretaker relatives, the elderly, blind, and disabled. Medicaid is a federal state program. So states administer the Medicaid program, but that's within federal guidelines. There are costs shared between federal and state governments. In Kentucky, our approximate match is around 70% of federal funding. So any services, reimbursement methodologies, and so forth have to be approved by the Centers for Medicare and Medicaid Services, and they have to be outlined in our Medicaid state plan. Similarly, any changes to eligibility, reimbursement, or covered services must be approved by CMS through the submission of a state plan amendment. And when we go to the next slide there, we're going to see just some more interesting dates, historical dates. Let's go on to the next slide. So with regard to the evolution of Medicaid, as we said, signed into law in 1965, adopted within Kentucky in 1966. And here are just some major occurrences, throughout the years. I want to call out 1981 being the year that the home and community-based services waivers were created. So we'll hear more about those later. And then obviously throughout the years, several different adjustments to percent of federal poverty levels, certain populations that can be covered, Medicaid expansion, and that sort of thing. So just some interesting historical points there with regard to the evolution of Medicaid. And let's go on to the next slide. Within Kentucky, our Medicaid delivery system is primarily through two different methods. We have fee-for-service, which is where you're going to find our long-term care services, PACE, Program of All-Inclusive Care for the Elderly. This is where our 1915C home and community-based waivers fall. IDD, or Intellectual and Developmental Disability Services, fall under fee-for-service. And this type of delivery model, again, is for folks who are receiving supports to remain in homes, in the community. These are like personal care supports, activities of daily living, and that sort of thing, just at a high level. On the other side, we have our managed care organizations that have that MCO service delivery model. This is predominantly for children and adults, other than or outside of those people who fall into that elderly or disabled population, folks with disabilities. The MCOs must cover all the services that we have outlined in our Medicaid regulations and in our state plan. There is some negotiation on rates with those providers. MCOs do have the flexibility to deliver value-added services, and those value-added benefits will look different from managed care organization to managed care organization. Some of those might be transportation to job interviews, or covering educational classes or other services that wouldn't normally be covered. And there, that last bullet on the right side does identify the managed care organizations that currently have contracts within our state. So we can go on to the next slide. I'm going to start narrowing it down here. We're going to take the larger conversation down and talk about long-term services and supports a little bit more specifically, so we can go into the next slide. So what are long-term services and supports? These can be institutional or home and community-based. Long-term services and supports, or LTSS services, just in general can be required by individuals of all ages with different types of physical or intellectual disabilities or complex conditions. And our state does happen to offer both institutional and home and community-based options. So let's go to the next slide. So again, within our state, we have our home and community-based LTSS options, which would be those 1915C HCBS waivers. We have Kentucky Transitions, or Money Follows the Person, Program of All-Inclusive Care for the Elderly, or PACE, Home Health, Private Duty Nursing, and then we have our hospice services. These would be our home and community-based services. Kentucky also offers institutional level long-term services and supports, and those would look like your nursing facilities, your ICF IIDs, intermediate care facilities, or institutional hospice services. We can go to the next slide. So we're going to keep narrowing down a little bit here. Let's get into that subsection of LTSS services. That is our 1915C home and community-based services waivers. We can go on to the next slide. Thank you. So the HCB waivers actually complement the coverage that's available under the medical state plan, under the Medicaid state plan, as well as natural supports. So these 1915C HCB waivers offer services individuals who are, again, aged, have a disability, but they want to remain in the community. In the community being you're living in your home, you're living in a family home, or you're living in some sort of residential selection, a residential home that you've selected. And I did see a question pop through. I'm hoping we can sort of hold questions and we'll get to them at the end. Let's go on to the next slide. So when I say state requirements for 1915C HCBS programs, this is really the states are required by CMS to make certain assurances and adhere to certain, obviously, rules, regulations, laws, statutes, and so forth. So this is what this is speaking to. So in order to have the authority to operate a 1915C HCB waiver, a state must do these things. It's our responsibility to determine eligibility, so who's eligible, the types of services that are being offered and what those look like, the settings that those can be offered in. It's our responsibility to set rates and manage those payments to providers. We're also required to, within a waiver provision, we have to be able to assure that what's being provided is a level of care that's equal to what an individual would receive were they in an institution. We've got to demonstrate that the cost of care in the community is equal to or less than what that same care would cost in an institution. And then finally, we do have to assure that the quality of services and the report and supports that individuals receive, meet standards. We do receive federal dollars to pay for the 1915C HCBS waiver programs by meeting these requirements. On the other hand, if we don't meet these requirements, we do risk losing the ability to have the authority to administer these programs. So let's go on to the next slide. In terms of eligibility for waiver services, so as I stated in the prior slide, we have to ensure that a certain level of care is met and that the services provided within a waiver meet the same quality and the same level of care as would be provided in an institution. So from that perspective, individuals to qualify for a waiver must meet an appropriate level of care, and that level of care is different depending on the waiver that we're talking about. So we're going to get more in depth in a couple more slides. The need for services must be due to a person's disability and not related to age-related or age-appropriate dependencies. So these are the types of levels of care that we have within our current waiver programs: nursing facility level of care, intermediate care facility or ICF level of care. So nursing facility is more of a high intensity nursing care, rehab services. These are going to be complex medical needs that can only be performed or supervised by a professional. Another qualifier there is an unstable medical condition with at least 2 care needs in certain designated areas, or a stable medical condition with at least 2 care needs in specific areas. This is very high level. The links that are up at the top of this slide will actually take you directly to these regulations, so you can read them more in depth. Intermediate care, this is for intellectual disability or related conditions, deficits in at least one activity of daily living, and requires a planned treatment program. And with our newest child waiver, we've actually introduced this 3rd level of care, which is hospital inpatient psychiatric for people under the age of 21. Okay, let's go on to the next slide. So within a waiver, although individuals must meet the financial qualifications for Medicaid, so you do have to meet Medicaid eligibility, but there are special financial considerations when applying for 1915C HCB waivers. Let's go on to the next slide. So in order to apply for Medicaid for waiver services, we do have that first step of meeting Medicaid eligibility. That is determined by reaching out to our connectors or a DCBS office. The Medicaid eligibility process is a different process than waiver eligibility. One has to be eligible for Medicaid first before being able to apply for waiver services. So let's go on to the next slide. This is a snapshot of our 7 1915C waiver programs. We have our acquired brain injury, home and community-based waiver, Michelle P. waiver, acquired brain injury long-term care, our Model 2 waiver, supports for community living or SCL, and then the new Community Health for Improved Lives and Development or CHILD waiver. We'll go through on the following slides just a little bit more information about each of these. Yep, you can go ahead and move forward. So our ABI waiver and ABI LTC, these are both brain injury waivers. These are for individuals who are 18 or over. They would have to meet that nursing facility level of care. The ABI waiver itself is a more acute rehab-focused waiver, whereas the long-term care waiver focuses more on long-term intensive supports. Next slide. Now we're going to look at HCB, our home and community-based waiver. This is specifically for people who are age 65 or older and or have some sort of physical disability. The requirement here is also to meet nursing facility level of care. Model Waiver 2. This waiver is designed for individuals who are ventilator dependent 12 or more hours a day. They do have to be on an active physician monitored weaning program, and the level of care here is also nursing facility level of care. The next slide, we're going to get into our Michelle P. waiver and supports for community living, SCL. So Michelle P., this waiver is designed for individuals that have an intellectual or developmental disability. Individuals in this waiver can meet nursing facility or ICF level of care. SCL is also for folks who have an intellectual or developmental disability. The level of care here is ICF level of care. And I think we've got one more. Our child waiver. This waiver is for children and youth who are under the age of 21 that have high intensity behavioral health, intellectual or developmental disability needs. The level of care here is an ICF or inpatient psychiatric level of care, but again, can be safely supported at home or in the community with the right set of services and supports. Next slide. Within the waivers, the package of services is going to vary, again, based on the population that waiver serves and supports, the types of services that are required there. But in general, this is sort of an overall look at the types of services that are offered within our 1915C HCB waivers. So we've got things like goods and services, environmental minor home modifications, respites, community access or community living supports, supported employment, residential services, counseling behavior supports, adult day trading. So waiver participants, in addition to the services that they're accessing through the waiver, also have access to all of the services that are outlined in our state plan. So the expectation is that someone is supported by a combination of those Medicaid services, the state plan services, waiver services, community programs, natural supports, all working together to be that, that set of services and supports to help a person live independently and be successful. Next slide. So waiver services in our state are offered through 3 different service delivery models. The first is traditional. This is when participants use an agency to deliver all of their waiver services. Participant-directed services. This would be an option in which participants can hire their own employees to provide services for them and get paid to follow those services and supports as they're detailed on their person-centered plan. And then that last service delivery option would be a combination of the two. So receiving some of your services through an agency and then some of your services through employees that you have hired. In the next slide, please. So in addition to those 7 1915C waivers, I wanted to just make sure that we had information out there regarding other long-term services and supports programs and sort of how they fit in as well. The next slide. So Kentucky Transitions, or Money Follows the Person. This is actually a federally funded grant. This is designed for people who have been in a nursing facility and have been there for more than 60 days or 60 days or more, but who at this point in time could live safely in the community if they had that wraparound set of services and supports. So Kentucky Transitions really offers that assistance in transitioning out of a nursing facility and back into the community. They have specific transition coordinators and housing coordinators to help find places to live, to help manage, getting all of the details and things in place for a move that big from a nursing facility back out into the community. In a handful of our waivers, we also have an approved set aside of slots that we can specifically tap into for these transitions as they arise throughout the year. So that when someone's coming out of a nursing facility, if they qualify for a waiver service, we can transition them right into a waiver service when they get moved out. The next slide is going to give a bit of information on Program of All-Inclusive Care for the Elderly, or PACE. So PACE is fairly new in our state. We just kicked this off in 2022. PACE is a program that does provide comprehensive services to people who are 55 and older. They do need to meet nursing facility of care, but they can continue to live at home, again, with the right sets of services and supports. So that people who would qualify would enroll with a PACE organization. And once enrolled with the PACE organization, that organization is really tasked with meeting all of their needs, whether it be preventative care, acute care, long-term care, social needs, that sort of thing. So once that PACE organization steps in, they really are responsible for that continuum of care for their enrollees. Another thing here, we did meet a milestone with our PACE program this year. We are actually over 1,000 enrollees statewide. I think the last time I checked a week or so ago, we were around 1,025 folks who were enrolled in PACE services, which is fantastic. Next slide. Home health and private duty nursing. These are services that have to be physician ordered and follow a specific written plan of care by that physician. So home health would be services that would be like for in-home medical care due to an illness or an injury. These are short-term in duration. Typically what we'll see is nursing care and then like PTOT, so physical therapy, occupational therapy, speech therapy, supplies, that sort of thing. Even education with other family members or supports that are going to be taking on, care needs in the future. So there's our home health piece, and then we have our private duty nursing piece. This is in-home nursing care due to disease, illness, or injury. This could be ongoing in duration. These services are provided specifically by registered nurse or licensed practical nurses. And this can be covered when the member's care needs sort of exceed those normal activities. Okay, next slide. Hospice and institutional hospice. So the hospice service can be provided in-home, in a nursing facility, or in an intermediate care facility if we're talking about folks with with intellectual disabilities. These services would be for people with a terminal diagnosis and a life expectancy of 6 months or less as certified by a physician. There's a range of services here: nursing care, home health, mental health services, supplies, physicians, short-term inpatient stays for pain control, symptom management, that sort of thing. And I know this has been something that's come up in the past, so I really like this bullet here. Hospice and institutional hospice services are available to people who are on a waiver, one of our 1915C waiver participants, if the services are not already offered in the waiver program. The next slide. So now we're getting outside, we've stepped sort of outside of that realm of home and community-based services, and we're looking at our institutional care. As we mentioned earlier, institutional care looks like nursing facilities, ICFIIDs, or intermediate care clinics. And those operate sort of differently. So your nursing facility, there's a per diem rate for individuals who need high intensity nursing care or rehab services. That rate would include room and board, equipment, facilities, nursing care, and all the other services, supplies, and supports that would come with being in that nursing facility. Intermediate care facilities for individuals with intellectual disabilities. This is a 24/7 facility-based care for individuals who meet that specific level of care. And again, without going through all of the in-depth nature of that regulation, there was a link earlier in the presentation that will take you so you can, if you wanted to read through that. ICFID services would include, again, medical, social, behavioral, therapeutic services, just that full range of services. Intermediate care clinic. This covers services provided at an intermediate care clinic. So medically necessary, preventative, diagnostic, therapeutic, rehabilitative, palliative services. In order to qualify for these services, individuals must have a mental illness, an intellectual or developmental disability, and meet the ICF level of care. Next slide. So that's a lot of information. There is a link to our sort of homepage, our landing page. There are lots of resources there. There are lots of other links that you can click to find out more in-depth information about any of these programs. Again, this was just meant to be an incredibly high level. We have so many programs, so many options out there. So again, just very brief information. And then we could go to the next slide there. It should be a listing of the various ways to contact us or to contact our sister agencies who do some of our waiver administration. So if you were to want more information on any of those topics specifically, there's resources there. We encourage you to reach out. Okay, and I think that might be the last one.
I think we have on waivers, that is the last one. I think we have one more slide that has the waitlist numbers as of March 30th. And they did receive this in a handout, so we can go very quickly over this one.
Oh, fantastic. Okay. So these are the numbers as of this Monday, so just a few days ago. As you can see, it shows, I'm just going to go quickly. We do have a 1 there all the way on over the far right for ABI LTC. That person actually has capacity, so that is already moved back to a 0. So there is no waiting list in either of our ABI waivers, the Model 2 or our child waiver. For HCB, there are 6,958 people on the waiting list. Michelle P, 9,688. and SCL 3,841. Once we take a look at people who are on multiple waiver waiting lists, so we count each person on the waiting list one single time, the number of people there unduplicated is 16,486. I do want to mention that if we look at the bullets there at the bottom, waitlist updates, so 17.5% of the people on a waiting list are on more than one waiting list, sometimes 2 or 3 waiting lists. So I really want to focus not on the 20,000 number, but more on that 16,000 number. It is really of note that 30% of people that are indicated in that waiting list number actually have an allocation and are receiving services in another waiver already, but they're still being reflected as in a wait list position in these figures. And then 78% of the people who are on a waiting list do already have an active Medicaid benefit that allows them to receive Medicaid services and benefits in some other form or fashion, whether it be through state plan, EPSDT, PACE, or some other program or method. And I know that you all got this earlier to review, so.
That was all.
Questions? Okay.
Okay. Just to keep us moving forward, I don't have any hands raised. There are a couple comments, questions in the chat. Carmen, if you want to address them. Other than that, I'm just going to go ahead, Megan, and have you move us forward.
Okay. Kent, I saw that one come in from you. I think that's an important question. Kent asked, what is a natural support? We do use that terminology, I think, quite a bit. So if it's a term that people don't understand, a natural support would be someone in your life whose natural role would be to be a support to you. So for instance, a parent, a step-parent, a spouse, a natural support could even be a friend or someone that you know in the community who essentially is supportive, who's encouraging, who's an advocate, who might provide assistance in community engagement or involvement or volunteering or whatever it is, but who's not paid. So this would be just someone who has a natural relationship with you. Again, whether it be a family member or a friend, who is providing, some set of support, advocacy, guidance, assistance, but in a non-paid way. Let's see. And natural support can be people, also be community resources and supports that occur naturally in everyday life. Thank you, Aisha. That's great. I think you did better than I did. Can HCB waiver ever provide meds management? Okay, so Molly, this is a yes, but it depends. So one of the qualifications for nursing facility level of care, which is what applies to HCB, is that you have certain needs or limitations, and some of those might be that you cannot successfully manage your medications on your own. In that case, there are certain services and provider types within the home and community-based waiver that can assist with meds management. For instance, an ADHD. If someone's attending an ADHD, those folks are going to have clinicians there who can help to load, pill planners or help specifically with that meds management service. So yes, in certain cases. Does PACE provide any services in the home, such as cleaning assistance? Another good question, Molly, and I'm hoping that Alicia or Aaron is on, because I think I know the answer to this, but I don't want to say anything wrong.
I am on and I'm trying to get my camera on so that you all can see me. Good afternoon. My name is Alicia Clark, Assistant Director in Long-Term Services and Supports. And so PACE is responsible. We pay a per member per month capitation payment, and any medically necessary services to keep them in the community is, would be approved. Now, all services are approved through the interdisciplinary team. So there's actually a team of several different disciplines that meet daily. And so it is possible that if they need some type of homemaking services, if that's approved through the team, then that could be covered through PACE. But they cover everything. So there's not any services that are billed to Medicaid. They are all, the PACE program would be responsible. Thank you, Carmen.
Thank you, Alicia. Nina, I see a couple hands. Go ahead. Yes, ma'am.
Yeah, I put a comment in the chat that I just want to make sure people are aware of, and that is that when Medicaid was enacted in 1965, they also established the Institutes of Mental Disease Exclusion, which was patients between the ages of 21 and 64. If they received care in a psychiatric hospital or residential treatment center with more than 16 beds, the provider wasn't paid. And I think Kentucky has done a good job in working with the MCOs to override that, or not override it, but work within CMS parameters for those individuals to be paid. But I just think it's good to remember for behavioral health, there's been a long-term discrimination.
Thank you for that, Nina.
Sure.
And Molly, I think I saw your hand up too.
Yeah, I just had a question about the PACE. I know you said that they had to be approved by committee. We have had a lot of PACE referrals that we've sent over, and they've been rejected because the person wanted cleaning assistance in the home or services in the home. And I was wondering, is that approved? Because a lot of times people need that as well as to go to the adult day. From my experience, the PACE program has more been ran by like an adult day instead of like a comprehensive services in the home and then also that medical care. So I was just kind of curious about what the regulation was on that.
And Molly, I will be more than happy to, as soon as I get done talking, because I'm not good at doing two things at once, but I will grab the CFR and place it in the chat for you.
Okay.
But if you have any specific examples, obviously we're not going to talk about them here, right? PHI and all that. But if you want to send me somebody that you believe that meets nursing facility level of care and would maybe need those and maybe they were denied, I will be more than happy to take that to reach out to the PACE organization that covers that county. And we'll take a look and we'll work with them to see if maybe there was another reason or something like that.
Yeah, we're also receiving rejection for people that meet nursing home level of care because they are saying that their needs are too much. So it's kind of hard to figure out like what is that eligibility, because if they meet nursing home level of care, they're going to have great needs. But then PACE is saying, no, their needs are too much.
So one of the qualifying factors is they have to be able to live safely in the community. So, again, without looking at specific cases and working with the PO, I don't want to provide like an overall statement on that. But if they don't believe that the individual can live safely in the community, then they would not meet the upfront criteria. But again, if there's anybody, don't hesitate, send it to me. Also, Erin Bickers is the branch manager. and she's great to work with too. But we can take those and definitely look into those for you. I would just need, a Medicaid number or date of birth, some type of identifying information to be able to try to figure that out, and any documentation that you may have.
Okay, thank you.
You're welcome.
And Molly, that sort of caveat piece that Alicia just gave, in terms of meeting nursing facility level of care, but can live safely in the community at the time of enrollment, because we understand that that situations are going to change and people's needs are going to change, and they may, they may regress or come to a place where they can no longer live safely in the community, and that's okay. The PACE organization at that point, once they're enrolled, is now responsible for those services and supports, whatever they may be, as their needs change. But at the time of enrollment, they need to be able to live safely in the community. Thank you all for your time. Thanks.
Thank you, Carmen. Do we have any other questions? Okay, then let's go ahead and move on to the TAC.
I was notified at the beginning of the meeting by Cody Hunt that the TAC hasn't met yet this year, so they don't have any updates, but they will be meeting on May 15th.
Okay, thank you. There is a new submission form for the tax, and the reports now will be submitted online, and the online application or submission form is pretty straightforward. You just enter your name, your email address, and then the recommendation or any key item that you want to submit to the MAC on the form. And there's a place where you can type in your recommendation from the TAC or your comment or question that you have. And then some other simple questions are, is there a quorum? And you're submitting the recommendation and the date of the recommendation. I have to say that I searched on the web, and I could not find the place where the form is available. I had the form sent to me because I'm the vice chair, but as far as the tax go, I don't know how to access that. I searched all over the website and could not find that. Looking at the tax and searching in keywords and looking under the MAC. So I think that information would be important.
Hi, Dr. Barton. Yeah, this is Helen with Altarum. I can note that this is a form that all TAC chairs will have access to, as they're the individual tasked with submitting those recommendations. We will make sure that it is clearly available to all TAC chairs and work with the team at DMS that supports that coordination to make sure it's available for the parties who will need it. But we do appreciate those TAC chairs that have used it for this meeting. And just will note, we are hopeful that this will streamline and make it easier. We can follow up with some communication with TAC chairs if there's any questions remaining about it. But I think I thank you, Dr. Parton, for highlighting this new process. I think we'll be able to continue moving forward with it and see how it goes, but we welcome any questions about it from TAC chairs as they submit their recommendations as well.
Okay, thank you. And then one other point is that it would be preferred to enter your recommendations or your comments 7 days before, but we know that sometimes the TACs are meeting just the day before the MAC meeting, and it is okay to submit it the day before, and it'll be addressed at the MAC meeting. So to my question, Helen, what are the forms available? Can the TACs see that? Because when I went to the individual TACs, I could see where the meetings were and I could see the agendas, but I could not see any link to.
Yeah, so the link is for the TAC chairs to submit what is approved by a quorum in their meetings. So TAC chairs will have access to that, and as per I believe most TAC bylaws and the MAC bylaws, the form will be submitted, and that is the approved process for it being submitted to the any recommendation being submitted to the MAC and then discussed at these meetings.
Correct. Okay. So
Yeah.
the chairs can see that link. It's just that I'm not a chair, so
Chairs have that link. It is not a public link.
Okay. Okay. And then just a little bit off topic, but similar. I could not easily find a link to the MAC meeting for today. When I went to the site for the MAC, there was no link or list of meeting dates or anything. I really had to search hard to find that. So I was wondering if that could be added to the MAC.
Okay.
page.
So it is on the MAC page, the Medicaid Advisory Committee page under the CHFS site. It is on the right hand of the page there. But we'll always make sure that it's up there and available, the meeting link.
Okay. Okay. Well, I couldn't see it, and I searched a lot last night for it. So anyways, having said that, well, let's move on to the TAC recommendations. And I don't know how many TACs already have comments or recommendations that they submitted, but I do know that behavioral health has recommendations, and Steve Shannon is going to submit those.
Correct. Thank you, Dr. Parton. Steve Shannon, I serve on the Behavioral Health Act. Dr. Schuster, I'm doing my best to fill her shoes, large shoes, to present this recommendation. We met on March 12th and had a detailed discussion about the prior authorization system. And we had some concerns expressed, primarily relating to WellCare, and they are now requiring a prior authorization for individual, family, or group therapy. And that was not the previous case, and that was retroactive to February 1, I think. So the recommendation of Behavioral Health TAC, initially there was a quorum present, so we met that criteria. Behavioral Health TAC recommends that the approval granted by the Kentucky Department of Medicaid Services, other requests made by WellCare, MCO, to begin requiring prior authorizations for outpatient, individual, family, and group therapy be rescinded. This recommendation is made due to concerns from the BHTAC about the PA process delaying the initiation of individual, family, or group therapy when those services are needed by Medicaid members. Delaying care or reducing access to clinically recommended care only worsens symptoms, triggers crises, and frequently leads to costly ER visits and/or hospitalizations that timely therapy likely would have prevented. It is also noted that historically, both commercial insurance and managed care organizations have historically not required PAs for outpatient, individual, family, and group therapy services, and no other Kentucky Medicaid MCOs are currently requiring PAs for these services. So that's our recommendation from the Behavioral Health Act. And again, we had a quorum, and we met on March 12th.
Thank you, Steve. Any questions? Okay, I would like to tag on to that.
1 second. There was a hand raised. Sorry to interrupt you.
Okay.
Hi, this is Chelsea AG with the Department for Medicaid Services, the Contract Monitoring Branch. Good afternoon, everyone. Good morning, almost afternoon. I just wanted to touch on what Mr. Shannon was discussing with the H0004. So after the last meeting, we did meet internally with the commissioner's office, and we did send a retraction for that approval to WellCare that was sent to them on the 19th of March. And just to read you kind of what we described in that, I'm just going to read it to you all. But we stated basically we are retracting the approval of the document to allow further internal review. We stated that H0004 is a prolonged therapy code intended to be used based on clinical judgment during the course of a therapy session. By its nature, utilization of this code cannot be reasonably anticipated in advance, making it inappropriate for a prior authorization requirement. And then additionally, the current approach described allowing providers up to 24 hours post-service to request authorization creates an administrative burden that is not aligned with the typical clinical workflows and is not a practical expectation for providers. This is particularly concerning given that H0004 is recognized on the fee schedule as an add-on prolonged therapy code. So we have asked them to rescind that or retract that, just, based on the recommendation provided. So hopefully, that you all will not be seeing that going forward until that comes back to us for review with the change that they've made to that document.
Okay, appreciate that. So would that be effective March 19th?
So we retracted it March 19th. So yeah, effective the day we asked them to rescind that letter.
Okay.
That would be our expectation.
And there was a comment in the chat. Does this apply solely to the H0004 code, or does it apply to the individual group and family therapy code as well?
Well, the entire document itself was rescinded. So
okay.
It'll have to be the entire document itself really has been rescinded. So we just called out in the response to them the problems with the H0004. But the document in its entirety has been retracted. So WellCare will have to resubmit any documentation, to the department for review before that is approved or denied or updated.
Okay. Thank you, Chelsea.
You're very welcome.
Chelsea, what I was going to say is that we've received a notice from United Healthcare that all specialty referrals will require a PA. What you just said, will that apply to that as well?
I would have to take that back and look at the particular notice that you're describing. I'm not aware of that concern with United in particular. So if I do see Sherry may have, Sherry Staley with the department may have some information there, but I would have to look into that particular document for United. But I can definitely take that back and follow up.
Okay, because this is something new that has just popped up, and I think really inappropriate when you're trying to make a referral to a specialist for any reason, why you would have to get prior authorization. So who do I see?
Hi, Dr. Parton. It's Krista Hensel. Sorry, I had to step away for a moment. What was the question regarding United?
Prior authorization for any specialty referrals.
That is not the case in the Medicaid space. There is some work going on in our Medicare Advantage plans, but that is not relevant to Medicaid.
Okay. All right. Thank you. And then we have, do we have any other further questions for Steve? Okay, thank you, Steve.
Dr. Parton, if you have questions around the Medicare Advantage clinical policies around authorization, I'm going to drop my email in chat. Feel free to reach out to me. I'm happy to connect and talk through that offline.
Great, thank you.
I also chair the Reentry TAC, First Return Society for Incarceration. We are so excited that the waiver went live yesterday. We appreciate the great work Medicaid's done. They attend our meeting. We get updates from Angela Sparrow, and she's just been a great partner in that process. And we appreciate that from the Reentry TAC perspective.
Okay. As far as another TAC report, I understand that dental has a report, and Dr. Bobrowski was going to give that.
Yes, and I was, thank you, Dr. Parton. I was just going to give this report. Dr. B.J. Millay is the new chair of the TAC, and he said he did send this report in, but I don't know if he sent it on the quote authorized form, but I'll follow up with him on that. But the Dental Technical Advisory Committee submits the following recommendations to the Kentucky Medical Advisory Council pursuant to its advisory role in evaluating access, quality, and administration of services within Kentucky Medicaid. Recommendation 1, the TAC be involved with fee review as it relates to DMS and dental services. The support on that is to allow for codes and services to be reviewed by active providers to make recommendation regarding codes that are really being seen in daily treatment. Allows to develop network adequacy by having provider input regarding fees and services to have a triple win supporting patients, providers, and practices and the state. Recommendation 2, public posting of dental credentialing processes and timelines for dental providers and other providers as related to their specialty. The format should be easily viewable and able to locate. Should address the following: contracted dental benefit administrators and direct contact of state dental director, regional directors if applicable, and provider relations team members. Dental credentialing and recredentialing requirements, credentialing timeframes, and effective dates. The support on that will help maintain adequate provider networks to ensure sufficient timely access to covered services, allows for transparency, requires submission and public disclosure of information necessary to monitor access in the network and compliance. DMS has clear contractual authority to standardize and publicly post credentialing information to support provider enrollment and network adequacy oversight. Recommendation 3, evaluation of a single source dental credentialing model. The Dental TAC recommends DMS evaluate and report to the MAC on feasibility of implementing a single source dental credentialing entity for Kentucky Medicaid, either administered by DMS or through a contracted credentialing organization applicable to all MCOs and dental subcontractors. An example is CAQH. With the goal is to decrease administrative load on small providers and practices. Allow DMS a standard uniform process of credentialing dental providers, increase network adequacy monitoring. Allow DMS to implement corrective measures when administrative barriers impair providers' participation. Respectively submitted Dental TAC Advisory Committee, Dr. Robert Millay, Dr. Caitlin Patel, Dr. Joe Petrie, Dr. Justin Kalasa, and Dr. Jay Cruz. Thank you.
Thank you. Any questions? Okay, thank you, Dr. Bobrowski.
You're welcome.
Do we have any other TAC reports or any other TACs who want to make comments?
So this is Megan from Altarm. I'm just going to jump in. Those were the 2 TACs that we did have submissions from on that form. So that should be who we have speaking.
Okay, thank you.
And then I'm
ahead.
going to flag to just, I know we're a little over. We might have had some people drop. I want to make sure we still have quorum before we move to voting. Or Aisha, if you could check that.
Yes, I'm just.
While she's doing that, Beth, I know that the hospital tech met and they had recommendations, so I'm a little confused about, I guess they just got caught with this new process of submission. So we'll have to hear from them next month, but I hope that there aren't other techs for which this new submission process has precluded their report to us.
Right.
So instead of trying to go through all 100 participants, I'm just going to call out the MAC members that were here earlier and make sure that we're still here. Beth Parton.
Here.
Catherine Hanna.
Here.
Dr. Dwight Burchett. Sorry.
Here.
Eric Wright. Is Eric still here?
He's on. He is
here?
Still in the participant list.
Okay. Heather Smith.
She's also on the list.
Thank you. I'm still here. Kent, you're still here. Kendra Marsh.
Not listed.
Okay. If Kendra's not here, then we do not have quorum. We only had 14.
Aisha, this is Emily Beauregard. I'm still here, and I don't know if you counted me, but
I did count you.
okay,
Yes.
okay.
Let me double check before I went.
And it's Nina. I'm still here, so I don't know if you counted me.
And I'm Susan Stewart, and I'm still here.
Thank you. Oh, I'd miss Susan, so let me recount it. Is Theta still here? Or Zachary Hart?
Zachary had to leave.
Zachary had to leave. Yeah.
Okay. So that would make
Aisha, I just did a sweep through too, and I agree with you. I do not think we have quorum with the members still on.
Aisha, this is Dr. Bobrowski. I don't know if you counted me or even if I am allowed to count. I'm taking the place of Dr. Kalasa for a while because he's had operating room conflicts with the times. So he and the Kentucky Dental Association asked if I could fill in for him for a while. So
I think that we only have 13.
Yeah, I think with all those that can be counted, we do not have a quorum. But I understand that. I also believe there was some, additional conversation around the behavioral health recommendation, if that warranted any changes to what was submitted. But yes, I do not think that there is a quorum at this time.
All right. Well, then we won't be able to vote to accept the recommendations from the tax. Unfortunately. Okay, any new business?
I don't believe there was any submitted ahead of the meeting for new business, so we don't have a list of items to call on, but is there anything to be raised?
It's Nina. I was confused about the notifications. I got two different ones for the MAC meeting. One said it ended at 12 and one said it ended at 12:30. So are future meetings from 10 to 12 or 10 to 12:30?
The meetings are set to be 10 to 12. There is
Okay.
not, I think that must have been a typo. Apologies on that, Nina.
No
I didn't
problem.
see that. If that were to change, there would need to be a vote on it as a group.
Helen,
Thank you.
Helen, this is Angie from Medicaid. Ooh,
Yeah.
I have two invites too. I don't know if Nina's talking about
Okay.
that or not. I actually have two distinct invites, one to 10 to 12 and one 10 to 12:30. So I can look
Okay,
to
perfect.
see who submitted the 10 to 12:30 one and let you know.
Yeah, Angie,
Okay,
that
thank
was
you so
what I
much.
got too.
All right. Well, we will definitely check on that, Angie. Thank you so much for confirming that.
Mm-hmm.
This is
I
Emily
also believe.
Beauregard. Oh, go ahead.
Go ahead, Emily.
I was just going to say, I think I mentioned this at our last meeting when we went over, and I think it's worth saying again that we should probably go until 12:30. I think a 2.5 hour meeting is necessary. We've had a lot of good conversation, and I feel like we're always going to be cutting it short and losing our quorum if we don't extend it to 12:30. So I would say at our next meeting, we should vote for a 2.5 hour meeting.
I agree, Emily and Nina.
Okay, we can
Yeah.
definitely meet that. Yeah,
And
exactly like you were saying, Emily, for the quorum can't vote on it today, but we can do that. We can keep that on the list for the next agenda.
Yeah, and Ms.
Ken,
Dawson,
you
I
want to say
think, yeah,
something?
yeah, I think we also ought to consider, because there will inevitably be people who need to leave at certain points. I think we ought to consider moving TAC recommendations to a different place in the agenda so that we can
Yes.
give them our full attention. We can approve them with quorum, and in most cases, discussion on these items is usually brief because they've been vetted by another committee. But had we done this in the first 15 minutes, we might have not had to delay approval.
I agree with you, Ken.
That was a great point, Ken. Thank you for raising that.
Really quickly back to the multiple kind of meeting invites floating around. I know the United Healthcare team struggled to get on at the beginning of the meeting. The Zoom link in the Teams meeting invite that came to emails was different and distinct than the Zoom link on the MAC website. So just another small logistic item to clean up going forward so that we all get to the right meeting at the right time.
Okay. Yeah, we'll connect with DMS about checking on what meetings still exist in the Zoom account to make sure that there's no confusion, because it might be a holdover or a different invite that is conflicting. So we'll definitely check on that. Apologies for the confusion and the issues with joining that may have caused today too.
We all got here. It was good.
Do we have any public comments?
We should
have. Yes, I do believe that if Danny Davis with DMS is on, I think she was tracking those for us.
Yeah. Can you all hear me?
You're echoing quite a bit, but we can hear you.
Is this better?
Not so much.
Okay.
But Dan, if you want to put anything into the chat, I can help facilitate too. Thank you.
Do we have anybody else?
We're just letting Danny chat in individuals that had signed up. There was the public comment process too that is on the website as well. So I think if there were submissions there, that's what we're waiting to see from Danny.
Okay.
All right. So Leona Mahone, if you are on today with us, are you able to unmute and share your comment? Okay. I don't see you on the list as of now, but if you are, we'll come back to check again. Joseph Miner, are you on the call today and able to unmute and share with us? All right, we don't see either of these individuals present, so I think at this time we'll need to continue on through the agenda.
I think, again, this is Emily. I think similar to what Kent said earlier about moving things on the agenda, it may make sense to move this up as well, close to the beginning of the meeting, because it's not really even, I think, respectful of us to make somebody wait 2 hours for a public comment. So in the future, it just makes the most sense for us to get business that needs voting and public comment out of the way first.
Yep, I think another great comment raised, Emily. There's always quality improvement that can go from agendas that have been the same for a long time too. So I think that both of those shifts can be addressed. All right, so Megan, can you continue us on? Yes, okay. Dr. Parton, we can turn it back to you.
Okay, thank you. In closing, our next meeting is June 4th at 10 a.m. There will be a feedback survey, and I think we've got comments, at least 3 or 4, that we may want to submit into those comments. And then, since we don't have a quorum, we won't take a vote to adjourn. So thank you, everybody, and appreciate everybody giving their time to come to this meeting. Okay, we are adjourned.
I have a question.
Thanks, Ashley.
For Dr. Bobrowski, I cannot speak this morning. Will he count where he's in for Dr. Colasa, or
Yeah,
will that?
thank you, Aisha, for raising that. We're DMS is coordinating with the Dental Association on like the formal nomination things that are needed, approvals that are needed. So at this time, we're still confirming.
Okay. So at this time, not part of quorum.
Correct.
Okay. All right. If that changes, just let me know.
Of course. Yeah. We'll completely let you know.
Thank you very much.
Okay. Thank you, everybody.
Thank you all. Have a great rest of your day.
Bye-bye.